everybody. Thanks for joining us again on our Monty Hardcast conference. Which I'll be moderating today with one of our fellows, Shunsuke. Um, and it's a real pleasure to have a really good friend, Anita Asgar from Montreal Heart Institute, who's probably, I think, one of the best structural heart operators in the world, particularly when it comes to mitral. I always look to you, Anita, to learn and gain from your experience. So I'm delighted you're going to teach all of us how to do better transseptal punctures.
Well, thanks so much. And it's a great, thank you for this fantastic opportunity to speak to you this morning. So I'm going to talk about transseptal puncture. Azim gave me the difficult task to come up with my own topic, and nobody ever asks us that. They always just give us something. So I thought this might be useful, particularly for those who perhaps don't do transseptal very frequently. So it's going to be some basics to a few advanced techniques. I have no disclosures. So this is a little about what we're going to talk about. It looks a tad intimidating, but we're going to get through this pretty quickly. So I just want to give you a brief history of transseptal catheterization, talk about the anatomy of the intraatrial septum, indications for transseptal catheterization and the tools. And I'm going to talk about two techniques for doing this. Probably the majority of my transseptals are done under echo for structural intervention, but for diagnostic, I do them all under fluoro. So I'm going to show you two ways of doing that. Talk about some new interesting technology that's available, and then talk about the thing we hate the most, which is management of complications. So transseptal puncture has been around for 60 years, imagine it. First described by John Ross in 1959, a lot of this work done at the NIH and developed really for looking at pressure measurements. So in the 1960s. In the 1970s, this became a popular technique, obviously, for mitral valvuloplasty. 1980, electrophysiologists sort of took this on for ablation of left-sided accessory pathways. In the 2000s, this came back in interventional cardiology, especially for those of us who weren't doing mitral valvuloplasty, for paravalvular leak closure, pulmonary vein isolation for electrophysiology. Between 2005, 2010, we saw this really getting popularized with LAA occlusion, MitraClip, and probably we're going to see a lot more from 2020 on for transcatheter mitral valve replacement. So again, this is just another graphic showing you a bit the evolving indications for transseptal catheterization. So for those of us who do structural intervention, this is really a necessary tool in our toolbox when we want to do some of these fancy procedures. So to start, we really need to understand the anatomy of the atrial septum. We can't actually puncture anywhere, and we need to understand this. We need to keep this in our minds for the three-dimensional anatomy to make this easier. And so I like this diagram because this shows you the neighborhood of the interatrial septum. The true septum itself is really only a small part of the atrial wall because you can see there's a lot of other structures associated. And it's really a triangular area of the fossa ovalis, which is the area of the septum inferior to the fossa near the orifice of the tricuspid valve. And the fossa ovalis is in general where we want to puncture. We can puncture outside that if we have to, but this is generally where we want to be. And this is located quite posteriorly. So you can see here the superior vena cava, the inferior vena cava, and the fossa is quite posterior. And this is at the junction of the mid and the lower third of the right atrium. And this is really where we want to be. So this is a septal surface. You need to know what's above you, what's below you. So what's above you is the superior limbus, and this is really just an infolding of the muscular and the thinner septum. And what's below you is the inferior limbus, and this is what goes down into the tricuspid valve. So this is just a cross section to keep in mind. These are the important structures you need to know. And you can see this well on echo. You see the superior limbus, this thicker part of the septum, and the inferior. The place that's most important is this little zone in blue that I've shown you, which is the transverse sinus. And you don't hear a lot about it. It's an important structure to know because when you're doing your transseptal puncture, this is a space just posterior to the aorta that you can get into, that you will see no pressure tracing, and that the next structure you may hit is going to be the aorta. And so something to keep in mind that when you're advancing your needle, and I'll show you a little bit about the hemodynamics, that if suddenly you start to lose your pressure, you might want to be concerned that you're here because the next thing you might see is an aortic pressure. So keep the transverse sinus in the back of your mind. This is just another diagram, and for those of you who do ASD closures or are interested in that, this is something else to keep in mind, the different parts of the atrial septum. These are the things we need to measure, obviously, when we're doing an ASD closure. So I like this image because this is an MRI image, and I also do imaging with MRI, and this just shows you the relationships. Sorry about that. This just shows you the relationships. You can see your left atrium is quite posterior. Your right atrium is anterior. You see your vena cava on the bottom, your SVC on top. And so this is a video that I'm going to play, which again just shows these structures in relation. Whoops. Sorry, my son is in the picture. So my video doesn't want to play, but anyway, you can see the relationships of these structures. If I go back one. Yeah, so you can see these are structures. Basically, you see the right atrium is anterior, the left atrium is posterior. You can see that septum, and if you could imagine the way your catheter comes up in the IVC, you want your catheter to be directed a little bit posteriorly. Obviously, if your catheter is directed too anteriorly, you're going to end up in the aorta. So just to keep those little landmarks in mind. We'll skip ahead across this. So when we think about why we want to do a transseptal puncture, diagnostically, there's not a lot of reasons. The majority of times this is being used for therapeutic or interventional procedures, but there are some times when a transseptal puncture can be helpful for us. And in terms of hemodynamic assessment, you know, if we have equivocal cases by echo, we can use transseptal puncture to assess transaortic gradients in terms of patients who have mechanical valves, and you can get this simultaneous pressure of the aorta and the LV, or in patients who have pulmonary disease in which you may be concerned when we're assessing a mitral gradient that the wedge pressure may overestimate or underestimate, in particular, the mean mitral gradient. So this is a nice example. Here we're trying to measure or evaluate a patient with mitral stenosis, and you can see we've got a simultaneous LV and a wedge pressure tracing, which is giving us a mean gradient of 15. This patient also has lung disease. We do a transseptal puncture, and now we realize that our mean mitral gradient is 6. So right now you've gone from an indication perhaps for surgery to only moderate mitral stenosis. So in terms of therapeutic indications for transseptal puncture, as you can see, there are numerous, and this is perhaps the workhorse for transseptal puncture is really therapeutic interventions. So valvuloplasty, MitraClip, valve-in-valve, mitral valve replacement, paravalvular leak, EP procedures, less common now, but still an option, tandem heart, so percutaneous left ventricular assist, and LAA occlusion. So if you're going to do a transseptal, what are the tools of the trade? What do you need to have? What do you need to know how to use if you're going to actually do this? And essentially, you need to have a sheath and you need to have a needle. As you can see, there are numerous choices in terms of sheaths. A lot of these that you see in panel A, these are electrophysiology sheaths that they use for various pathway ablations. For interventional cardiologists, for the most part, we use a Mullins or perhaps an SL1. Or you can even use a steerable sheath, which you see in panel B, which is the Agilis. In terms of needles, you've got a couple of choices. You have essentially your Brockenbrough needle, as you can see in panel C, your BRK, BRK2, BRK1. There are different curves depending on the anatomy. And then you have a radiofrequency needle that I'll talk a little bit about later. So I'm going to start with a fluoroscopic technique. This is a technique that it's, I think, important to know, and those that are doing it are well experienced or perhaps in their sort of retirement phases. So it's important to keep this technique alive just so that you know how to do it. Historically, that we've done this under fluoroscopic guidance. I've tried to put some of that fluoroscopic anatomy there for you. And for the most part, it's quite sufficient to achieve transseptal catheterization. But you do need to know your landmarks. And so what I've showed you here is the landmarks in the RAO, and then of course the landmarks in the LAO. And as you can see the spine, you see where the left atrium and the right atrium are. In general, when I do this, I put a pigtail in the aorta, just so I know where the aorta and the aortic valve are. And so you can see just, in general, where is all your anatomy. I tend to do this in the AP and the RAO, and that's what I'm going to show you. So if you're going to do the transseptal puncture or the fluoroscopic technique, I've sort of broken this down into 3 steps. The first one is positioning. You can see all these images are in the AP. The second step is engagement of the septum. And then the third step is the actual puncture. So positioning. So in order to do this, a couple of things you need to understand is about the actual needle itself. And I put a little diagram here on the bottom. The needle has a little pointed hub, which allows you to direct the needle to different positions without actually seeing the tip. You know how you're moving it by looking at the hub. And so to first position your sheath, you want to advance that up into the superior vena cava. You do that either over a O32 or O35, depending on your sheath. And I do this in the AP projection. And then you're going to advance your needle up into your sheath, but you're not going to exit the sheath. And the key to remember is to think about the clock. So you can see my clock here on the bottom. And when you start your puncture, there's a couple of ways to do this, but I'm going to show you the way I do it. And that is I position the needle at 9 o'clock. So that the needle is pointing, not exactly in this particular image, this is the way it's pointing at 9 o'clock, but oftentimes you're going to see it's pointing a little bit laterally away from the spine. So you're going to keep it at that position. And I've tried to point out to you just with some images here where the SVC-RA junction is and where I'm sort of targeting for the fossa ovalis. In this particular case, I don't have my pigtail in, but often I'll put a pigtail in the aorta so you can see where it's anterior. And so now to engage the septum, you want to move this assembly as a unit, and you want to retract back from the SVC, which we know is posterior from our MRI image. And then you want to bring it down and engage the fossa ovalis. And when you do this, there's two jumps. Now, you can start at 9 o'clock and retract and turn. So what you can see on the little clock here, what I do is I start at 9, and then I retract and turn to 4. And that will engage me with the fossa ovalis. The EPers like to start at 3 o'clock, so turn more medially toward the spine, and then just pull down on the needle, and then they'll see these jumps of the system as it goes under the aortic knob, and then as it drops down into the fossa ovalis. So I use either of the ways, but I generally teach my fellows to start at 9 o'clock and then retract downwards, and at the same time turn my needle to 4 o'clock. And at that point, you should feel some tenting, or you should feel some contact. You should feel that you're engaging something. And so at that point, you advance the needle into the left atrium, and then you can verify your position by aspiration or measuring LA pressure. I do all these under pressure so I can verify the pressure, and I'll show you that. Once you've completed your puncture, you would then turn the needle to 3 o'clock because now you want to go a little less posterior as you advance into the left atrium. So I'll just show you here. Once the needle is engaged, you want to make sure, that you're not too anterior or you're not too posterior. So at this point, I would move from the AP view into an RAO view. And I like the RAO because I can see my spine. I have showed you a left lateral here and on the right panel. But in the drawing, you can see I'm showing you the RAO that I use. And when you see the RAO, you should see your pigtail anterior, and you will see your spine posterior. And you want to be between the two. Too anterior, you may hit the aorta. Too posterior, you're just going to go out the posterior wall of the right atrium. So sort of put that little sweet spot in blue. That's where you want to be. And you can also go into the left lateral, which you can see on the right panel, and you see your aorta, the pigtail anteriorly. You see the spine posterior on the left side. And again, it's the same sort of thing. You look at that sweet spot and you're trying to aim in between the two. Once you've done that, you should be able to see, you should be transducing pressure the entire time, and you could do this through the needle. And so here's just an example where you see the right atrial pressure tracing, and then as you're going through the septum, you sort of see this flattening, and then the next thing you should see is that left atrial pressure. So obviously, for diagnostic, we're not too picky about where we cross. We want to cross the fossa somewhere. It's not as important where we cross, but obviously for interventional techniques, we need to be a little more sophisticated on where we're going to cross. And as a result, echo is a lot more useful for that to give us a targeted transeptal exactly where we want to be. And so it's important for us to understand echo imaging either by ICE or transesophageal echo. For the most part, it's transesophageal echo because we need them to guide our procedures. And so I'm going to show you some images and things you need to understand about transesophageal echo. On the far right, there's a nice picture here, and I'll show you the resources at the end where you can get some of these images. But you can see that depending on the procedure you're doing, your transeptal is really targeted to certain areas of the fossovallus. And we'll talk a little bit more about that in detail. So for transesophageal echo, there's 3 views you need to know if you're going to be doing this. The crucial ones are bicaval, short axis, and then the 4-chamber. And so you can see from this little diagram in the middle how each of these views are cutting the septum to show you what you need to see. So you can see if you look at line number 1, the bicaval view, you can see where you're cutting the septum. Line number 2, which is the short axis, will give your position in the septum relative to the aorta and the posterior wall. And then that 3rd line, which is the 4-chamber, will show you your height. Where are you cutting in terms of your height in the septum? So for transseptal puncture for TE, again, I'm just showing you 3 steps. I like to make this as simple as possible. So we always start out in the bicaval view. We want to see the fossovallus. So this is the TE at 90 degrees. And you can see your images. You see some very nice tenting here on the bicaval view. And you kind of want to be in the center in general. And you can adjust your height, obviously, more on the 0 degrees or the 4-chamber. And in the second panel, you see your TE at 45 degrees. So this is the short axis. And you can see, it's not the greatest image here, but you can see your aorta is anterior, your posterior wall is here. And so you can see your sort of mid-septum here as well in terms of your puncture and your tenting of the needle. And I tried to get you an image here where we're measuring, but this is a 4-chamber view, particularly for MitraClip. This is important to assess how high we are above the mitral annulus, and this is at the 4-chamber is 0 degrees. And these are the only 3 views essentially you need for transseptal puncture. So here again, going back to this image and trying to understand if you're doing an intervention, where do you need to puncture to facilitate your intervention? And so for MitraClip, which is the thing I like to do the most, you can see we need to be superior and posterior, and for a lot of these other interventions as well, this is the site of puncture. So you can imagine blindly on fluoro, this is not particularly easy to achieve, but on TEE, we can see this well. And then you can see inferior-posterior more for an LAA occlusion, superior anterior if you have to puncture for a transseptal PFO closure for whatever reason. Atrial septostomy, not something we're doing a ton, but probably coming up a little bit more with heart failure and some of these devices that we're going to be doing more of this. And then sort of inferior anterior for other interventions. Unfortunately, as good as we can be with TEE and the current technology, there are significant limitations to what we have. And so we have these fixed curve needles that you can see that I showed you previously. We have different curves. We have the BRK, BRK1, BRK2. But a lot of us who are doing this are often adjusting the curves of our needles ourselves to get us what we want to do. And so the curves are fixed on the needle, but we can bend them. And a lot of us are doing that to give ourselves a better curve to get where we want to get. And so the technology is somewhat limited. Some of the other things we find is some of these needles can slip when we're trying to puncture in a particular place, and we don't always end up where we want it to be. And so you can see here is an example with a traditional needle where the needle actually slipped, and you can see my puncture is a lot more anterior than where I wanted it. And for a MitraClip, that's not optimal, and that can make our lives very difficult. And in terms of height, this is another challenge we often see for septums that are really floppy. You can get a lot of excessive tenting if you've got a very compliant septum. And then we often need to do a lot of, put a lot of force on the needle to get across. And the problem is you don't know where the needle is going to end up. And so this is sort of an exaggerated drawing that I've done here, but you can see some excessive tenting. And then once you give way, you're quite close to the pulmonary vein. So you have some risk of perforation with some of these conventional tools. One of the tools I like to use is the radiofrequency transseptal needle, which is just like it's a BRK. It has a C0 or a C1 is the name of the needle. But essentially, it's exactly like a BRK, except it's connected to radiofrequency energy. And so what happens is once you have your appropriate tenting, you apply the energy and you cross. There is no excessive tenting. The tip is radiolucent so you can see it. And there's some other sort of gear that comes along with it, a generator, et cetera, that allows you to really do a targeted puncture where you want. I know some people prefer to do the poor man's version of this, which is to connect it to a bovie. I don't actually do that, but that's another option for those who don't have this available. The advantage, obviously, is you don't need any mechanical force, and you can cross outside the fossa if you have to. And so in some of these cases where you really have to get high and you're in that thick part of the septum, this is a great technology to allow you to do that, because you can just burn across. You do have to dilate the septum, but there's minimal damage to the septum, minimal tenting. So you can essentially cross anywhere you want with this type of technology. And so it looks exactly like a regular needle. It comes in different lengths, and it comes in different curves. I still have a tendency to curve this one on my own anyway, if I don't get the curve I like. But again, it's another tool that can really be helpful. And you can inject and you can transduce pressure just like you can with any other needle. So this has been one of my workhorses. I'll show you what I use now, sort of advanced away from this one, but this is a great thing to have in your toolbox as well. I'm going to skip ahead out of this one and just show you this. I don't know if it's going to play. It may not. No, unfortunately, it's not going to play. But, you know, this is just what you see is you'll see some bubbles as you go across, and you don't see any of the excessive tenting. So there's even newer technology out on the horizon. The DRG, the radio frequency needle, is a little bit old school even now. It's about 10 years old. And so now there's some new technology. This is a flex point steerable transseptal. So this allows you, instead of to manually manage the needle tip, you can actually steer this as you like, and put this in and steer this, as you can see on the video, with a little knob that allows you to turn. So this is some newer technology for transseptal puncture. And as you can see here, there's a little control knob that allows you to steer. The back is quite similar. You can transduce pressure from the hub, and you can adjust your tip deflection. We'll just, you can see that. I'm going to turn off the sound. And so this is the neutral position, this is partial deflection, and this is full deflection. The other thing that's interesting about this, you can actually do it when you're in contact with the septum, and you can see, so this is just you can see the actual catheter is deflecting with deflection being put on the needle. So you can see that adjustable deflection, and you can even do it when you're in contact with the septum. So you can see here, they don't like their position very much, and they're actually actively deflecting when they're in contact with the septum. So that's an interesting technology. I haven't used this one myself, but this is also available. And Jason Rogers has presented and published some data on this in left-hearted structural procedures in 27 cases, and he was able to deflect in all cases and achieve his optimal tenting and exactly where he wanted to puncture. So this is a new tool that we can use if we find the existing tools don't meet our purposes. I'm going to talk a little bit more about this one. This is my new workhorse technology for MitraClip and any of my left-sided procedures now, and this is called the Versacross. This is made by Baylis, the same company that makes the RF needle. And I'll show you what I like about this, but this comes with a shapeable dilator, a sheath, and an actual RF wire as opposed to an RF needle. And what I like about this is it just makes the procedure much more efficient. So I'm going to show you how this works. So this is the radio frequency wire. You can get a J tip or a pigtail, and I'll show you. I prefer the pigtail, and I will show you why. And you have a radio frequency tip. This is radio frequency right at the tip of the wire, and you can actually see very well on fluoro the little radio frequency tip. And everything else is exactly what we're used to. We have that hub on the back of the dilator, so we can direct 9 o'clock, 3 o'clock, what we're used to doing. So it's exactly similar feeling, even though we don't have a needle. And the dilator is very stiff. You can curve it if you want. And this is the RF wire, so you can see, whoops, I'm moving ahead here. So I'll just show you, this is a standard transseptal puncture. So this is what you would normally do. You would go up with your J wire, you would put your Mullins or your SL1 sheath in, you'd pull your wire back, you put your needle in, you'll cross, you'll take out the dilator, you'll pull in another wire, and then you'll put in your sheath. Let's say, for example, this is a MitraClip. So this is essentially 12 steps. But if we do it with the Versacross, we now have a lot fewer steps, because now what we do is we put in our transseptal, we put in our J wire, we put in our transseptal sheath. Instead of the J wire, I actually takes the pigtail from the get-go, and then I bring down, I cross with the radio frequency tip, of the wire, and now I just have my J tip, my pigtail wire in the left atrium, over which I just advance my my MitraClip system. So it's essentially 3 or 4 steps as opposed to 12. So we've submitted our early experience to CCI, but just to show you, so what I do is I go up into the SVC with this pigtail wire, which is small enough that it goes right up into the SVC. Then I put in the dilator and the catheter over that wire. Sorry, I keep skipping ahead here. Right. So then I just go over and I put in the system over the wire, retract the wire into the catheter. I get my tenting, I look at my images, and then I just radio frequency and I advance the wire inside. And so now I'm done, and then I can put my MitraClip sheath over this wire. It's stiff enough, and it's a pigtail wire that I can put everything inside. And so here's just a video of this. You can see my pigtail wire. I just turn on the radio frequency, it goes across. And then after that, I'll just advance the dilator and the sheath over to get across the septum. I'll pull out the dilator and the sheath, and I'll put my MitraClip system right in over that. So it's just a much more efficient system. My transseptals have gone from about 20 minutes to get my guide catheter in to now about 5 or 6 minutes to get my guide catheter in. So it's just a little bit faster. So we're going to end by just talking a little bit about troubleshooting and how to manage complications of a transseptal. In general, this is a very safe procedure. Our institution does about 350 transseptals a year amongst 3 operators. It's safe. Major complication rate is only between 1% to 2%. But what you need to know is if you do have a complication, it may be life-threatening. And so we do need to know how to manage these as quickly as possible. The first step is really to avoid any kind of complications, make sure our patient selection is appropriate, that we know what the contraindications to transseptal puncture are, and we know how to manage our anticoagulation. So the really only absolute contraindication to transseptal puncture is thrombus at the actual interatrial septum. Thrombus in the LAA is not an absolute contraindication. It is a relative contraindication for most of us, but the really only absolute is to have something on the actual septum. Relative contraindications to INR greater than 2. That being said, many of us will do it under echo for MitraClip, et cetera. So it's a relative contraindication. Marked cardiac or thoracic deformity, again, you're probably going to need TE to do those when you have significant scoliosis or someone who's had a pneumonectomy. Fluoroscopic guidance is probably not optimal. A hypertrophied or aneurysmal septum or previous patch are not a contraindication. I do find, however, that I need radio frequency if I'm doing a transseptal with someone with a previous patch or very hypertrophied. So if we're a little bit outside the fossa, you often are going to need to use some more of those advanced tools to do that. So common troubleshooting to keep in mind. So you're doing your transseptal puncture and suddenly you have no pressure. Obviously, the thing that always concerns me when I see that is, am I in the transverse sinus and am I going to see aortic pressure next? That's rarely the case, but you have to ask yourself when that happens, what's happening. You want to make sure that your flush is attached to the needle and that the lever on the back of the needle is turned in the appropriate direction. So if you look at the back of a Brockenbrough needle, there is the place where you would attach your flush, but there's also a little lever that moves. And if you move that in the wrong direction, it actually cuts off your pressure. So you want to make sure that's in the appropriate direction before you put your needle into the patient. And if you lose the pressure all of a sudden, you want to just look back and make sure your hand hasn't moved that. If you're still not getting a pressure, you're probably best to withdraw the needle. If it's been taking you some time, you may have a thrombus on the tip of the needle. So you want to take it out of the patient and flush it on the table to ensure there's no thrombus formed. If you have a damped pressure tracing once you're safely in the left atrium, you want to look at your catheter position on fluoro on echo. Particularly on echo, you want to make sure you're not up against the wall, because if you are up against the wall and you continue to advance, you may perforate. You can obviously aspirate the catheter to make sure there's no thrombus and flush it. If you aspirate air, you are probably against the wall of the left atrium or pulmonary vein and you need to bring it back. You need to retract the catheter and aspirate and flush again. So keep those things in mind if you're having issues with your pressure tracing. Obviously, complications, the worst one is cardiac tamponade. Varies according to what it is you're doing, obviously, but it's 1 to 3%. Patients may become bradycardic and hypotensive. And this is really important because prior to becoming hypotensive, a lot of them will become bradycardic. Blood in the pericardium can be very vagal. It induces a type of vagal response. You may not be sure what's happening at first. If they get bradycardic, they may be doing that before they get hypotensive. So keep that in mind. You want an urgent echo if you're doing it under fluoro to confirm the diagnosis. And obviously you want to be able to do a pericardiocentesis and drain that immediately. If you have thromboembolism, you obviously want to prevent that by flushing the needle frequently. So when I put my needle up into my catheter, it's always on flush. I try to do my transseptal quickly. If it's not quick, obviously you're going to need to retract your needle and flush it. And once you've gone across the septum, you need to give your heparin once the transseptal is done. Air embolism happens rarely, but it still does happen, and oftentimes it's clinically silent, but on the off chance, you may actually get ST elevation as those air bubbles find their way into the coronaries. So you always want to make sure your sheath is back bleeding prior to putting in any other devices. And if you aspirate air, and this is always the most important thing, if you're aspirating air, you're sucking the wall. So you want to bring your catheter back, you want to retract it, you want to aspirate. So just to finish up, Transseptal, it's an essential tool for any structural interventionalist, and we need to understand the anatomy, the tools, the different techniques to ensure patient safety, procedural success. Troubleshooting, knowing how to manage complications is very important. Structural interventions often require us to target certain areas of the fossa for transseptal puncture, and so we need to understand what those are depending on what we're doing. And there are some new tools out there that are there to help make our job easier and more precise. So these are some additional resources for those of you who are interested to read some more. These are great papers on, I love the one in Heart. That's a great paper, a how-to paper for those of you who are interested in more. The other one in JACC is a nice paper talking about what sort of interventions we can do. And this is a paper from where I trained in my fellowship at the Royal Brompton. This is some great anatomy stuff by Senyo. So looking at the connections in the interatrial septum. So thank you very much for your attention. I hope that was helpful.
Anita, thank you. That was fantastic. I mean, even as someone like me who does a lot of transseptal punctures, I learned a lot. Like I said in the beginning, I always learn from you. So I already texted the team to find out about Versacross.
I love it. I think it's a game changer.
I had no idea about it. I mean, I think I'm pretty, connected and I know what's going on. And I've tried a lot of the other devices. There's the TSP, Transseptal Solutions device. I've tried this. This looks really cool because it just cuts out so many steps.
So many steps, I'm telling you. And so we timed everything because I was convinced, like, I like to be fast. I'm trying to do transseptal, 3 MitraClips a day. And, this gets my transseptal time down from like 20 minutes to device to my MitraClip sheath into like 5 minutes. It's really something. So I love it. I highly recommend it. And the
wire is stiff enough. I mean, you can really push up the guide.
Yeah, absolutely. Yeah, because I was using their, not their Inoue wire. They have a wire, I forget the name of it now. It's a little bit cheaper than the Inoue. So I was using that. And this is just as good. So and the repositioning is super fast. Because it's a pigtail, if you're not happy with your positioning with the transept, you just re-advance the pigtail up into the SVC. Like, it's super easy.
Yeah, absolutely. And you start again. That's great. And it's a 035 wire, right?
It's an 035. That's right. It's ProTrack. Somebody said that. You're right. It's a ProTrack. And so I like it better than the ProTrack. I always got it. You have to take the long one. There's a short and there's a long. But I take the long pigtail. It's a little bit smaller pigtail than the ProTrack, but it does the job. And honestly, it's fantastic.
Okay.
And it's the same price. So, I was able to negotiate the exact same price as their DRG needle for the entire Versacross system.
Okay. Well, I'm going to be trying it next week. I'll send you a picture. Shun, I'll pass it on to you.
Good. Thank you for the, it was very complex, very comprehensive lecture by far that I've heard about Transseptal. So you mentioned, Dr. Latif, you mentioned about the TSP crosser, and I've seen it once.
Mhm.
Maybe, I mean, I didn't know there's so many devices out there for transseptal punctures. If you could maybe comment on that TSP crosser as well, the benefit of that. I saw that little loop can find the fossa easier. Um,
So I don't know, Anita, if you've used the TSP crosser.
I haven't. I've seen it, but I haven't
Yeah.
used it.
So I used it in Europe, and it's also now available here in the US. And basically, it combines a couple of things. So it's a steerable catheter. So it's like having an Agilis. Okay. It has this wire loop that kind of sits on the roof of the fossa. So once you put the wire loop and the loop is sitting on the roof of the fossa, the nice thing is you can just navigate around the fossa, and by curving, flexing on your sheath, you can go superior, inferior, and then you can go, rotating, go anterior, posterior. And so you can really find your spot within millimeters. So I think it's really nice. It adds something that particularly I think for both new people and when you're struggling to do a transeptal. I mean, I've had a number of cases where I just with a Brockenbrough and a Mullins just can't get to the exact point I want to, and then I'll switch to an Agilis sheath with a starter wire, and I'll use radio frequency on the wire to cross, just because I can't get to my position. So I think it's a useful tool. I think with all these tools, it's a question of, how much it costs in relation to what you already use, and how much
Agreed.
time does it actually save in the end. So I think the more and more, Shun, we're going to see more and more of these devices available just to kind of make the procedure easier for newer operators. I think, both Anita and I have done, hundreds, maybe thousands of transeptal punctures. But I remember when I started, it's a difficult technique to go up the learning curve initially. And so maybe these devices will make it safer and easier for new operators. But I got to tell you, for me, one of the big things I try to do is I'm trying to limit the amount of steps in the procedure and shorten procedural time, because we're all trying to be super effective and efficient and do more procedures. I really like the Versacross. I like the
Yeah.
fact
So,
that it's
so
one
I
system.
agree. Yeah. And one of the things I will say is, because I've been teaching fellows for over 10 years now, and one of the things I like about it is I teach the fellows how to do transeptal under fluoro. And it's exactly the same technique. So I don't want to have to teach the fellows different techniques for different technology.
Right.
And one of the nice things is that sheath of the Versacross is relatively stiff. It's like an SL1, so you can curve it if you need to make it the way you want. So I can get almost anywhere with it.
Okay.
And like I said, the repositioning. So I'd love to hear your feedback once you try it and see what you
Yeah,
think.
absolutely. I'm looking forward to doing that. Sure, next week we'll try it. How about that?
that sounds
Okay.
that sounds great. I have a question about heparinization. Um, I heard of cases where you cross and immediately you start seeing clots. So obviously you give heparin after you cross immediately, but do you give any heparin before crossing, or any recommendation on the amount, the timing?
Yeah, so it depends on what I'm doing. If I'm just doing a diagnostic and I'm doing it under fluoro, I don't give any heparin before. If I'm doing it for MitraClip and I have echo guidance, I may give 2,000 units before, and then complete the heparin if I get across once I get across. Now the Versacross is so fast that I just give a bolus of heparin after I get across. And I'll be honest, I don't see clots. I mean, I've been doing this for a long time. It's very rare that I see clots. Our patients who are chronically anticoagulated are on IV heparin when they come to the lab. We stop it about an hour before they get into the room, and then we cross. So it's been it's been exceptionally rare that I actually see that.
So Nina, that's an interesting question. So are you guys, I mean, because most of our patients with mitral clip are in AF and so on,
Mhm.
are you bridging them? Are you keeping them on heparin in hospital? And then after the procedure, are you restarting heparin? Are you avoiding protamine? Just maybe share with us a little bit what's your best
Sure.
practice.
So our patients come into the short stay unit for MitraClip, and they only are in hospital for 24 hours. So they'll come in the morning. And so if they're on Coumadin or a NOAC, I switch them to Fragment. So a lower molecular weight heparin. And then the morning of, they're on IV heparin. They get switched from their Fragment to IV heparin. After the procedure, I never give protamine.
Okay.
I don't like protamine for MitraClip. It's a venous access. I don't see any, we never see major bleeding from this. So I don't like giving protamine because oftentimes you might see smoke. If the gradient's like 3 or 4, you may see the smoke, and the protamine makes me uncomfortable. So I don't give protamine. After the procedure, I'll resume the IV heparin, and then the following day after their echo, when all is fine, I'll give them their NOAC. I just don't like to put a NOAC on right away in case there's a complication and they have to go to the OR. It's rare, but it's just my paranoia. I give the NOAC the following day.
Okay. But you are bridging them with subcut heparin in the timing stuff. Okay.
Yeah, because they're high risk. So I feel like, no one's had a stroke, but I feel more comfortable doing it.
Yeah, like I say, in Milano and here we hadn't been, and unfortunately we just had a really big stroke after a mitral procedure. That now I've become very concerned about the fact that we haven't been routinely bridging everybody, and that maybe we should be.
Yeah.
Carry on, Shin.
One kind of a question. After you finish the procedure and check the septum, what kind of signs do you look for? If you need, do you ever close the septum with the closure device afterwards? Does it usually close its own? And don't worry about the what the finding that you see on the TE that you're looking for.
Yeah, so over the years, I've been doing MitraClip for about 10 years now. It's very rare that I'm actually going to close the septum. So there's a few things that I look at to decide. So first of all, some of the septums will close, but a lot of them will not. I mean, it's still a sizable hole. It's about 6 or 7 millimeters. And so some of them will close. The more tenting or floppy the septum, those tends to close a little bit better than the others. Right after the procedure is over, the people I find that are the most at risk for needing a closure are those with tricuspid regurgitation. And the reason being is they tend to shunt. And so if you have severe tricuspid regurgitation or even moderate tricuspid regurgitation prior to doing your MitraClip, and a lot of these patients have combined disease that we know, if that jet is going across the septum, what I'll find is as soon as I pull my catheter across, they start shunting right to left. And if they're shunting right to left and their saturation drops, then I'm going to close the septum. If it doesn't, I won't do it. There isn't a benefit in a way to keep that little hole open, particularly, for the gradients, et cetera. I don't think it's a bad thing to have that small ASD. That's sort of debatable between a lot of people, but it's not my routine to close it. I will only close it in those patients who are shunting right to left and have saturations that drop. That for me is an indication to close. I don't know, Azim, what your practice is.
Completely agree. I do admit that we now more and more actively just spend a little bit more time than we used to before looking for bidirectional flow. I maybe close 1 or 2 a year because there's bidirectional flow, and they're usually exactly like Anita said, they're patients with severe TR or pulmonary hypertension or both, who, particularly when you get a really good result with your mitral clip and you drop the left atrial pressures a lot, suddenly, the right atrial pressures for a while are higher, and patients can feel it. I mean, we've had patients who we've had to bring back a few days later because they're becoming slightly hypoxic and are shunting bidirectionally. So exactly the same approach as you.
Oh, I think so the case that I think I saw, it was after a transmitral valving valve, where there was a valve septostomy with a balloon. I think that was the case that I was remembering. But when you do need to do septostomy, is there a recommendation on like what kind of size of balloons to get the device across the septum?
Yeah, so I've done some of these transseptal mitral. I did caisson before caisson was no more, but and for those we had to puncture quite high, and so what we would do is we would often end up puncturing in the thicker part of the septum. And so that's where the radio frequency was very helpful. I tend to puncture with radio frequency in those cases, dilate the septum first with an Inoue dilator because I always use that anyway. And they're quite atraumatic, so I will dilate with an Inoue dilator. After that, I'll often advance a balloon, and it's rare you need a hole bigger than 10 millimeters. So I like to take a balloon that's sort of semi-compliant and then advance it up into the septum and then just very gradually dilate. So I use something called a PTX 20. It's a good balloon. It's a budget balloon. It's not going to break the bank, you know, and it's cheaper than an AGA sizing balloon. And I put that up, and it's 20 millimeters, so I can dilate just very gradually with that. That's all I've ever needed to use. I agree, those are cases when I've done that much work on the septum where I often may need to close. But again, I use the same criteria. So if they're shunting right to left, or there's a significant hole that I think they have now a significant ASD, then I will close.
So Anita, maybe let me ask you a little bit on that. There are many times where with mitral clip, you just can't get enough height. In the fossa, you know, you're getting sort of 3.5, 3.6. I mean, how often will you go on the muscular part and do your transeptal puncture? And any advice on issues or problems you've had as a result of doing that?
Yeah, so we all know that we can manage a mitral clip if our puncture is too high, but a low transeptal puncture for mitral clip can be a real disaster for steering. And so even if I can't be in the fossa, as long as I feel like I'm safe in the muscular septum, so I'm not too far posterior and I don't feel like I'm really going to damage the wall, I will go in the thick part of the septum. And that, I mean, I use radio frequency for every case. It's not really an issue for me. The only issue is going to be the dilation of the septum. And oftentimes, an Inoue dilator is enough, believe it or not. I've rarely had to balloon a septum, a thick septum, except for a TMVR. And so then I just use the Inoue dilator, and I'm patient, and you know, I leave the dilator in for a time, and then I'll go up with the system. But it really hasn't been much of an issue. Okay. And I think you're far better off being higher than trying to do a mitral clip with a low transeptal. Absolutely. It's really hard.
Absolutely.
There's a question about PFO closure. If you could go over about how to do transeptal for PFO.
Well, not only how, but when would you actually do a transseptal? Because here's the question, right, Shun? I mean, if it's a PFO, normally you cross the PFO, right? Close it. So when would you actually not, you know, do a transseptal to close a PFO? It's kind of
yes, I think that's a great question, and it's rare I have to do it, but there are a couple of times a year where I will have to do it. And so oftentimes what happens is you're trying to close your PFO and your wire doesn't go across. And you think, well, I see the PFO, my wire won't go across, at which point I'll do a bubble study just to make sure that that really is a PFO. And when the bubble study is positive, but I still can't get across, that's the time where I'll think about doing a transseptal. And then often in those cases, what you see is the septum is often very aneurysmal and you can't get across, or the angulation is such that your wire just won't come across. And that's usually after I've tried a few catheters to do it. And so I'll often try a multi-purpose catheter first, a JR4 first to try to see if I can get myself properly aligned with the PFO. If all of that fails, I'll do a transseptal. And like I said, I always start at 9 o'clock and do my rotation. But if I don't find I'm engaging the septum well, I'm sure you could start at 3 o'clock and come down. The key is if you're going to do a transseptal for PFO, it needs to be near the PFO because you're going to go across slightly above it, and then you want to be able to close it with the device. If your transseptal is far from the PFO, it's not going to help you because your device won't actually cover the PFO. So you have to be careful on where you're doing your transseptal. It can't be anywhere. It needs to be near that, that PFO so the disc of your device comes down and closes that PFO well. I think those are the key issues. And I recommend everyone who's doing transseptal to know how to do both techniques. So starting at 9 and rotating down, and starting at 3 and coming down, because sometimes depending on the anatomy, one technique works better than others. So I teach my fellows both, and I get them to try both of them. So you're comfortable doing both.
So the question on the chat is regarding that starting at 9 o'clock part. I think I've only seen starting around 5, 6 o'clock and coming down. What's the benefit of the 9 o'clock and
So
rotating?
well, you just have to understand how the anatomy is. So if you think about your superior vena cava, it's posterior. And so if you start at 9, your needle is sort of posterior lateral. And the plane of the septum is actually posterior medial. So by sweeping down and across, it tends to follow the direction of the part of the atrium and fall just generally in the fossa ovalis. So if you try it the next time, if you start at 9 and then gradually rotate, it's actually more 4:30 than 4 o'clock, I would say. But you bring that needle down, what you're doing is you're rotating posterior medially, and it tends to fall right into the septum. If you start at 3 o'clock, you're not really posterior at 3 o'clock. You're almost a little anterior. So when you come down that way, what you'll find on echo is that you tend to be much more anterior when you come down that way. It's okay if all you want to do is just puncture the septum. But if, for example, if you wanted to do MitraClip, anterior is never where we want to puncture. So, if you want to get across the fossa ovalis and just get through the PFO, it's more likely to be anterior. I think that's fine. But if you want to cross a little more posteriorly, like you would for MitraClip, you really want to be more at 4:30. So, you know, like I said, I think it's useful to know both techniques just to be familiar with both so that you have either option depending on the anatomy of the patient.
I have a question on, so there's more of research on intratracheal shunt devices, PEF. Do you have experience with those and any specific transseptal technique for those devices?
No, I mean, I think every device is sort of different in terms of where they want it placed. In general, though, they want to be in the middle of the fossa ovalis. So I don't think, those are just slowly trying to gain speed in terms of devices, but not particularly. I think if you're in the middle of the fossa ovalis, you puncture, you dilate, you put the device in. It's pretty simple, actually.
So I see, Shun, there was a question from Mark Menegas about when we're talking about bridging and so on, and he asked, why don't you just stay on a Coumadin or NOAC and not even bridge? Now, I know for LAA closure, there actually is a lot of centers, especially electrophysiologists, who do that. They will do a transseptal puncture or do the procedure, the LAA closure procedure, without stopping the NOAC because of their concerns about stroke. I haven't seen enough data, I have to admit, about the safety of that. I mean, Mark, we don't feel comfortable doing this with mitral clip because unfortunately, rarely there can be complications, large pericardial effusions that need surgical drainage or, damage to the mitral valve that may need surgical conversion. So we tend to stop for these kind of procedures because because of the potential that the patient may need surgical conversion. I don't know, Anita, if you disagree or...
No, I totally agree. I mean, I don't like to do any cases on a NOAC. I had a terrible experience of a patient who ended up with surgery with a NOAC and essentially bled to death. Not after a MitraClip, actually. It was after an embolized ASD device. But,
Wow.
It's a terrible thing when it happens. And yeah, I don't feel like we can reverse it. So I, in general, don't do anything on a NOAC if I can help it.
Great.
One more question on the chat. Do you change your transseptal puncture for left atrial appendage closure depending on morphology of left atrial appendage?
Not depending on morphology, but I don't do a ton of these, so I probably would, ask Azim what your thoughts are. Generally, it's an infra posterior puncture, but I personally, I don't have enough experience to talk about that. I don't know, Azim, what your thoughts are.
No, I think there are times when you have to change. If you have like a very chicken wing type LAA, where to get the right shape and place your particularly a Watchman device better, you may need to change your puncture depending on it. There's actually a lot of work, Mark Reisman and his group are doing a lot of work where they actually doing a lot of 3D modeling. They've taken tons of CT scans of patients with different morphologies, and they've created some software where you can predict based on the shape of the LAA, left atrial appendage, and the atrium, what catheter you should use and where you should do your puncture. Because there are some cases where you can get a better placement of the device by not being as posterior, which but I think there's a lot of work still there. It's not really that clear. I think the last question, yeah, maybe we'll have it as the last question from Muhammad Ali Shun is quite interesting.
Yeah, so how do you approach patients who already have interseptal device and say need a MitraClip or some other devices?
I mean, I think that's a great question. I've never done a MitraClip across a Amplatzer device. I think there are people who have done it. It sort of will really reveal a little bit about my biases. So I tend to prefer a device like a Gore for this exact reason, because I have crossed a Gore septal occluder before, and you can actually burn right across that with radio frequency. And then you can advance and dilate a Gore device much easier, because for those of you who are familiar with it, it has a nitinol wire and then Gore-Tex, and so you can get across. I personally have this sort of visceral reaction to putting a lot of metal in the septum, because my concern is if we ever need to get across, particularly for PFO patients who are young, if you ever need to go back there, it's not easy to get across the metal mesh of an Amplatzer device. I've never done it. I've seen cases in the literature where people have done it. I don't know if they've done MitraClip across an ASD device by an Amplatzer, but I have crossed a surgical patch with radio frequency, which are very tough to get across, a 20-year-old surgical patch, but it can be done with radio frequency and appropriate dilation. I've done MitraClips across those, and I have crossed a Gore device, and I've been able to do that without too much difficulty. I don't know, Azim, if you've ever had to do that across an ASD device.
I haven't, but I've seen a couple of case presentations of people having to do it. It's really challenging. You've got a balloon through the Amplatzer device and try and make a big enough hole in the device to get your sheath across. So it's not easy. Generally it takes up so much space that you can't go behind it or above it. So you generally have to go through it. I'm also, I've been, just because I trained, we use mostly Amplatzer, Anita, but I've also now considered that I need to start changing more to using Gore for closing these to leave myself access for the future. I still think, we need better devices for the septum.
Agreed.
Years ago in Europe, we were experimenting on a biodegradable device for closing PFO.
So I used to use the BioStar. I don't know if you remember that.
Yeah, I remember exactly. That's the one.
So I mean, I used the BioStar for years until the company went under. And then I switched to Gore, and it's because of that, because these are young patients and we don't know what they're going to need. And the idea of putting metal in there just makes me unhappy. So I really love the Gore. If you haven't used it, I highly recommend it. Super easy to use. They do have like a large cardioform for ASDs now.
Okay.
But I think it's an option.
Yeah, you could close with the ASD device, even the iatrogenic ASDs from a mitral clip or from a TMVR.
Yeah, so actually for all the mitral clips that I've closed, I've used a GSO, the Gore septal occluder.
Okay.
And the largest one they have is a 30 millimeter. It's what I use for all my PFOs. And you can close up to a 19 millimeter ASD with it. I've done that already.
Okay.
But they also now have the large, the Gore cardioform, the large ASD occluder devices.
Mm-hmm.
And so Bob Summers used a lot of these. Their trial, the Assured trial, is complete in the US now. But we did all their first in man work for that device. And it's a great device for ASDs. But when you get along the really, really big ASDs, like 35 to 40, you're probably still better off with an Amplatzer. But it's still it's a nice option for the ones who you want to preserve septal access, I think.
Okay. Wow. Cool. Thank you. Once again, I'm learning even more.
Well, thanks so much for the opportunity. I really appreciate it. It's been fun.
This was great. We all learned so much, and enjoy your vacation. You officially.
Thank you.
Thank you.
All right, take care.
Okay,
Bye-bye.
Bye-bye.
Bye.
Thank you.